Thank you very much, Dimitri. So we've heard four very different takes on the research agenda, how we can deal with it, what the values, what the problems are, and how we might face them. I really want to open this up to the audience now, to you, to ask of our panel questions, to take some comments, and to move this discussion forward. Sir.
I'm Bob Berg from the University of Pennsylvania. Dr. Gibbons, you showed some really exciting stuff of all sorts, and I would sort of remember about 16 years ago there was a Pulse Initiative, and as a result of the Pulse Initiative there was some money that was put into cardiac arrest and resuscitation research, particularly clinical research in ROC. During that next 16 years, we went from a paucity of clinical studies of cardiac arrest to an even greater paucity of investigators that were well trained to a large cadre of people that are now able to perform good studies in cardiac arrest, many of which that you showed and others have showed. At the same period of time, there has been very little in terms of translational research and animal research for cardiac arrest. If you would have asked me in 1999, where was our weakness in research for cardiac arrest, I would say we have terrible resources for clinical research. If you ask me today, I would say Dimitri was up there because he's the only person under 50 years of age. I think he's still under 50. He's the only person under 50 years of age that's funded by the NIH doing animal research. He's being brought up because he is unique. He shouldn't be unique. There should be, going along with what Dimitri said in terms of having a war, we have a huge problem here. If you and others at NHLBI wanted to make a difference in saving lives, as the numbers were shown by Christine Alberts and others before, this is an area where we haven't made much budging, and it's a huge problem. And we have to have a focus, like we did 16 years ago, to have a war on cardiac arrest and come up with ways that are going to also include basic science changes and translational science in laboratories, or we're going to be, we're falling behind the rest of the world right now, and I think this is a time that we should accelerate instead of fall behind in this area.
Thank you, sir. Dr. Gibbons.
I guess one response would be amen. Clearly, well, it's against the law for me to lobby for the appropriation of our agency, but certainly we appreciate the advocacy of the community that recognizes that our disease is still the #1 killer of both men and women in this country, and that we do need to continue to invest. I would dare say that the NHLBI's legacy has returned more dollar for dollar on the investment of the American people than perhaps any other element of our research portfolio. But clearly we have more to do. And so we certainly agree with you wholeheartedly that we'd love for some entity to double down on the investment. We leave a lot of great science unfunded as it currently is. So I would wholeheartedly say yes. Even despite that budget constraint, we are still focused, and I mentioned the Siren program. You mentioned the next generation. I dare say that I don't think there's any other institute beyond ours at NIH that is more committed to next generation with our K Award success rates, our early stage investigator bonus for RO investigators. So we're committed to making sure that we are training the next generation to go after the #1 killer. But we do need support to do that.
Thank you.
Thank you, sir.
Thank you. Bill Yesna from Johns Hopkins, and also a member of the Population Health Board at IOM that sponsored this workshop. As a physician and computer scientist, I want to comment on the data aspects of this. In particular, I want to make the point that, which has been alluded to, that we don't really have the outcomes data that we need, particularly the long-term outcomes data. And I've been struck in the area of cardiac arrest, which I am not an expert in, that much of the so-called outcomes data, or the data that's been published, relates to survival out of hospital or 30-day survival. And clearly, we need much more long-term data, and I don't think anyone would disagree. But the point I wanted to make is that EHRs are not going to provide that data. We do not have a system in this country for collecting long-term outcomes data, and we need to have such a system and use it in this domain, but also in other domains. Second comment is that the data we do have, we need to collect and organize in a patient-centric way, like the peer system that was just described. Thank you for that. And I think it's clear that we've done the experiment with health IT where we leave the data where it's created, in hospitals and in physician offices, and then try to put it together for later use, either for research or even for clinical care. We've pretty much proven that that does not work, and there's not enough time for me to explain why, but I'm happy to talk to people about it. That does not work. We need to have the data for each person in one place. And then finally, from a policy perspective, while it's clear that we need funding and effort in this domain, every other disease-specific domain wants the same thing. So not to in any way reduce the importance of this area, but let me suggest that it's very unlikely we're going to get funding to build a long-term patient outcome system purely for cardiac arrest. And it's very unlikely we're going to get funding to build a comprehensive patient-centric data system purely for cardiac arrest. But if we work with all the other folks who are working in different disease areas and build a comprehensive long-term patient-centric outcome system for all diseases, and we build a comprehensive patient-centric data system for all diseases for both research and clinical use, then by pooling our efforts, we may be able to make progress. Thank you.
Thank you, sir, for those three comments. Does anybody want to comment on, Nigel, do you want to, and Natasha, do you want to take a stab at this suggestion that we, rather than focus on one disease, we build the infrastructure for all diseases, and then cardiac arrest can be one of many beneficiaries of that research?
I clearly definitely agree with that, and I think it's because we've seen what happens when there are a number of different registries that come up, even within particular condition groups, and then you have 5 different registries, and then people don't know which one to use, and then it ends up feeling like a lot of times our decision makers that this is just a waste. Haven't we? I feel like we've been talking about registries for the past 10 years, and where have we gone? So I think really that idea of pooling the efforts together and pooling the lessons learned, I think being able to share that across condition group is really powerful. That's something that we've seen with peer in terms of different groups who think they have nothing in common, realizing their experiences are very similar. The key questions, the transition from one part of life to the next, it's all very similar. And also those groups have been able to learn from each other. So at this point now we have over 1,200 questions that are our common data instruments that are shared across a range of different condition groups that people saw and were like, oh, I have that question. I've seen that in my community. So I think it's really critical. And not to say that you just have something that's blank, but you start off with that template, you start off with that infrastructure, and then really piece out, oh, these are the things that really are focused on these types of conditions or this type of experience, or we have services in this area. But I think to continue to do kind of the one-off, there's just, for lack of a better way of saying it, people become really disinterested, and that's the worst thing, because it's usually right when we think we're right there, we finally have our act together, and we're like, oh, we're getting it, that then it's on to the next. And that's the really big loss. I think that's why we don't have that longitudinal data. We feel, oh, it took us 5, maybe 10 years to really get an understanding of this. We're ready, and it's too late. So I think those points were very key.
I obviously agree, and I think there are good use cases for this in Europe, for instance, in Estonia, the Scandinavian countries, of course, Sweden in particular, Singapore, and so on. One of the common denominators there is that they have a very different view over confidentiality, privacy, and so forth, including common identifiers, linked data. It's not just health data, it's social data, census data, all sorts of other data sources. No one data source is the truth. And we actually have to have a much more, I think, frank and adult discussion in our societies about how we're using data and for what purposes, including the quid pro quo. So if you can follow longitudinally individual patient life histories and so forth, generating insights and so on, we should be able to return those insights back to enable them to utilize those for things like health behavioral change, avoidance of health conditions and so forth. So we actually have to look at the quid pro quo for collecting this data for all stakeholders, but also how we can link and match that. And I think those items are very critical. But I think whilst we're mired in some of the challenges that we have, both legal and societal and so forth, of what the type of data is used, and what it's used for, it's problematic. We have, for instance, organ donation. In most countries now, opt-in, opt-out. Why are we not having data donation as a discussion in terms of donate your data altruistically for health research and so on? I often speak at a number of meetings. I often usually ask the audience to stand up, including like the audience here, and then I would ask those who were happy to share any or all of their medical data for research to sit down. And it's amazing, even in meetings like this, where this is exactly what we're asking for, maybe only about 50% of healthcare professionals, industry colleagues and so forth will actually sit down. The rest won't. So people have concerns even in our own industries over what we're trying to do. We need to address that, I think, in a very frank way and start to push this forward, I think, in terms of addressing linking data and creating large-scale data sources that can follow patients over decades, not just years or 30 days and so on. Couldn't agree with you more.
Hopefully we'll be able to discuss this more in the breakout session. We have two gentlemen over there, please.
Yeah, Henry Halpern from Johns Hopkins. I just wanted to expand on Bob Berg's remarks and relates to a lot of what Dimitri said. So if the new database, or if these databases and other kind of big data strategies and implementation are implemented fully, it would certainly improve outcomes. But to really make an like a quantum leap, you really need better therapies, because there's always going to be delays, and better therapies really are needed to bridge that gap. There's probably a golden hour for trauma, and there's probably a golden half hour, I suspect, for cardiac arrest, or maybe more, as Dimitri says, if you had the right therapies. And the only way those therapies are really going to be developed is by basic and translational research. And a lot of that is very biomedical engineering oriented. And I would just request that NHLBI reconsider emphasizing bioengineering research, because I think it could make a huge advance in these therapies related to improving outcomes from cardiac arrest.
Thank you, sir. Great comment. It's also worth noting out that there is an institute at NIH dedicated to biomedical research and biomedical engineering. So that's another way that NIH actually is more cross-cutting in terms of its approach. It's not wholly the work of NHLBI to, I think, to do all the work in biomedical engineering, but certainly perhaps a lot. So.
Yeah, Bob Meyerberg, Miami. So a point that might be of interest to the Genetic Alliance.
Could you speak up a little bit, sir?
Yeah, a point that might be of interest to the Genetic Alliance. In Japan, all children entering grade school as part of a general health assessment get an EKG. They get another one in the 7th grade. A recent paper in the European Heart Journal pointed out that the incidence of long QT in the school children in the 1st grade and 7th grade was about 2.5 times what we estimated to be from data from other parts of the world. So instead of 1 in 2,500, it was about 1 in 1,000. Importantly, unrecognized or untreated long QT, and when I say untreated, I don't mean defibrillators, I mean just beta blockers, accounts for about a 13% mortality rate between childhood and age 40, significantly higher than the overall rate. So there is a rationale for early recognition, both in terms of incidence and in terms of outcomes with simple, appropriate treatments. And I think one of the things that the Genetic Alliance might do for this is lobby the notion of generalized screening in school children as they do in Japan.
That's a great point. A gentleman survivor earlier spoke about this, and now we actually have some evidence to support that. Did you want to reply to that, Natasha?
Well, I have a hand in the policy initiatives that we take up. It's not solely my decision, so I can't say yay right this moment, but one thing that I actually do oversee all of our maternal and child health activities, and one thing that has been looked at here in the U.S. is what would we be screening for if we started doing screening at either 1 year of age or at that entry point into that school age. And of course, long QT has definitely come up, and it's one of those things that is not quite this topic, but what I really focus on is we do so much around newborn screening, and then there's nothing else. And so what are all those things that come at those different points in time? And to be able to pull that research and to show, because we know this is what happens. Once you start screening the population for something, it's, 2 times, 3 times more than what we anticipated. And we really have that opportunity to save lives. And so I think that's a really good point, and to be able to show the importance of looking outside of either just one condition, but also outside one country, but to be able to say, what are the models that are out there? What are the improvements that have been made? And then how do we incorporate that back here, and what are the opportunities for that?
Just for clarity, the European Heart Journal paper focused on long QT because it had genetic confirmation of the cases, but they picked up a lot more in terms of cardiovascular abnormalities than just long QT. So it is broader than the QT. I just quoted the paper because we also have mortality statistics.
Gary?
Just briefly, I think that's one of the opportunities for the sudden cardiac arrest in the young registry that is a collaborative project with CDC, and in which we might be able to learn more about that incidence, particularly as we develop greater understanding of the molecular basis of long QT and other syndromes like that, and appreciate that with the increased amount of genomic sequencing we're doing to understand the natural history and again, more about the incidence. So appreciate that comment.
Thank you. Let's go over that. So.
Yes, I'm David Belkin. I'm on the board of the Sudden Cardiac Arrest Foundation, one of the sponsors of this session. I got involved about 7 years ago when I survived sudden cardiac arrest, and I've been involved in this issue ever since. For the most part, this is a simple question, but I want to ask researchers on this. For the most part, we know what causes heart attacks, but will you be able to ever tell all of the people who have suffered sudden cardiac arrest what caused their sudden cardiac arrest?
Demetrius.
All
people. He wants to know if you can tell everybody.
Well,
you can do 99%.
Yes. I don't think so, but I think we will know very soon the cause of the cardiac arrest, the majority of the shockable rhythms. So it's becoming scientific fact that people that arrest suddenly from VFET, they do have a very, very high prevalence of coronary artery disease, and depending on the presentation, if they have ST elevation or no ST elevation, or they are refractory VF, that ranges from 30 to 70 to 90%. There are obviously other reasons, especially in younger children. The reasons for cardiac arrest are different than adults, but I think the etiology is becoming more clear and should be more targeted in order to see any improvement in outcomes. And as I said before, the realization of the cause of anything in medicine can be targeted as a therapy, because without reversing the causes of a problem, it's very unlikely going to make big dents into the survival of the outcome. Yeah.
Graham Nickel, University of Washington. Great set of talks. If I could respond to Demetrius's provocative talk, we began to do large randomized trials in cardiac arrest a few years ago because we were trying to capture some of the impact of large randomized trials in myocardial infarction. The idea of softening a significant p-value is an interesting one, but I think we need to be careful. If we look at what happened with the CAS trial, we discovered that when we did an adequately powered trial that we're actually hurting patients rather than helping them. But I wonder whether an alternative approach is to consider alternative outcomes. We usually use dead or alive because it's hard, but it requires us to enroll a lot of patients, which in this day of limited fiscal resources is a challenge. If we use something which is not so discrete, which is more granular or more short-term, we may be able to get to where you want to be with the resources that are available to us.
Thank you. Lance.
Yeah. Lance Becker from Northwell Health and a member of the committee and the IOM. I would like to direct a question to Dr. Hughes and Dr. Gibbons. My guess is NHLBI would love nothing more than to double its budget by a great deal of investment from companies like Johnson & Johnson. So my question is, what do the companies get out of it for Dr. Hughes? And for Dr. Gibbons, how would you be able to accept that kind of money?
Okay, just for point of clarification, it's not Doctor, it's Mr. Hughes, but in terms of the industry, it comes back to what I was saying about data you own and data you don't own. In the real world setting now, this is becoming incredibly important in terms of data being generated. And that's not randomized clinical trial data, it's observational to clinic-based data and so on. And we have to interact with it as an industry from discovery right through to post-authorization to commercialization of products. So if we can interact with a well-characterized cohort, understanding its natural history, disease progression, treatments, outcomes, and so forth, hopefully with access to samples or recall for samples, that's great for translational research, biomarker development, and so forth. The model of the industry doing all this on its own is dead. It has to collaborate. And I think most, if not all companies, whether large pharma or biotech, are recognizing this. But we have to understand what the quid pro quo is. It's not just based on money. It could be based on sharing of skills, sharing of technologies, sharing of actually the goals and the outputs of this type of research. So it follows on a number of different levels. We can invest financially, yes, we can give grants, we can give funding, but actually what's probably more productive is developing long-term, longitudinal collaborations which follow the patient journey over years and enable us to evaluate that in collaboration with clinicians, academics, patient groups, and so forth. So I think we have to have a much more sophisticated debate and discussion about how to interact between industry and those outside of industry in the market. But importantly, we need to understand what our common goals are, and ultimately it's about improving outcomes for patients, and in this case, obviously survival.
Dr. Gibbons, what would NIH and NHLBI get out of a public-private partnership? And how can they go and donate money to your
Yeah, I'll give you my bank account later. So I think, as you pointed out, we share the same goals, that it's about improving outcomes for patients. Obviously, that's our public service to the nation, and it certainly is part of their bottom line to their shareholders. I think there is opportunity for a win-win. It does start with the participant and the patient at the center of it. We should still want to know, for example, why a patient who gets state-of-the-art care and is on a statin still has a heart attack. That's a question that I think is troubling to all of us. I would hope that a patient who's on a statin would be willing to contribute their data so that we understand why it is that they seem resistant despite the fact that their LDL went down. I would hope that we could create a platform like precision medicine where we'd actually have the biospecimens, where we'd be tracking that individual and that cohort of people, particularly if we have 1 million plus, and be able to analyze more effectively who was it that had a heart attack despite a statin and who responded so well. I think we're starting to have the tools and capabilities to do that. The PMI with its biobank, with its ability to not only use AHR, but other supplementary information, and clearly with the omics that we can now layer on top of it, I think we can make those subphenotypes. I would love for industry to share all of its clinical trial data, in which it also looks at people who are on statins who still have a heart attack and don't. Certainly the NHLBI would be willing to share the data of AIM High or all of our studies in which we've again characterized patients on carefully managed protocols and had those same outcomes. I think there's a lot of opportunity for collaborative space in which we could share that data, and it would be beneficial to all because it would have that scale and capability.
So there are opportunities to share. Specifically to your question, Lance, the NIH fund exists. It's called the NIH. No, there's an NIH Foundation. NIH Foundation, excuse me, is an office where, if any of you are in the mood to donate to NIH, you can write your checks to the foundation. And for example, the National Football League about 2 years ago gave somewhere in the region of $30 to $40 million to the NIH Foundation that then directed that money towards the National Institute for Neurological Disorders and Stroke, among other places. So for those of you who would like to support the NIH in a philanthropic way, we can talk afterwards. I was going to ask our distinguished colleague, Dr. Kellerman, to make the last comment or question for the morning.
Dr. Brown, thank you. Just to offer a little food for thought as we depart for food, Tom Afterhardy, when he opened the conference this morning, noted that the overall survival rate for out-of-hospital cardiac arrest in the country is about 7%. Some of you may remember a paper that Camilla Sasson published a few years ago, a meta-analysis of 79 studies that suggested 30 years ago the overall rate of survival for out-of-hospital cardiac arrest was about 7%. That was hundreds of millions of dollars of research and thousands of studies ago. Did we do the wrong science? Or were the papers we published bad, or are we not applying consistently and rigorously what we know today to be effective?
Well, there's certainly some food for thought. Thank you, Dr. Kellerman. We certainly look forward to discussing some of these ideas in the breakout sessions. Now, everybody pay attention, because these are your directions for lunch. Please pick up your box lunches in the Great Hall out to your right. And then remember, please, that no food or drink are allowed in this room, and that the meeting staff do enforce this rule with cattle prods. And then we will meet at 12:10 to the breakout groups. Thank you very much to our panelists.